and welcome to Innovation in Medicine, episode number 5. My name is Rafael Fonseca. I'm a hematologist at the Mayo Clinic, and I'm delighted to be here today with Dr. Lanny Kirsch, who is an expert in minimal residual disease testing. Dr. Kirsch works with Adaptive Biotechnologies, and today we'll be discussing the background and implications of testing for MRD. Before I do that, I'd like to introduce Dr. Kirsch. He's a physician. He got his MD from Harvard University Medical School and then completed residency at the Children's Hospital Medical Center in Boston, Massachusetts, to be followed by a fellowship in pediatric hematology and oncology at the National Cancer Institute in Bethesda, Maryland. He did a 3-year postdoctoral fellowship in molecular genetics, working in the laboratory of Dr. Philip Leder at the National Institute of Child Health and Human Development. And then he went on to spend 20 years at the NCI as a basic researcher, as attending physician at the pediatric branch and the cancer genetics service, and ultimately was chief of the genetics branch within the Center for Cancer Research. And that's where I first met Dr. Kirsch. He has a research interest on the structure and function of the immunoglobulin and T-cell receptor genes and the use of probes for those loci to study cancer genetics. Has done quite a bit of work in basic biology, cancer genetic instability, and also somatic cancer genetics. In 2005, he joined biotech and pharma, first at Amgen as an executive director. He was head of the oncology research group at Amgen Washington in Seattle. He was an independent consultant to the biotech and pharma industry with extended assignments focused on the development of antibody therapeutics and molecular diagnostics, and currently serves as a senior vice president for translational medicine at Adaptive Biotechnologies in Seattle, Washington. He's extensively published, has authored over 160 peer-reviewed manuscripts and over 30 books, chapters, and reviews. So as you can tell from his bio, he's a true international expert in the topic we will be discussing. Before I go on to the conversation for our audience, as is customary, I want you to note that, of course, Dr. Kirsch is an employee of Adaptive, and I have served as consultant and part of the scientific advisory board to Adaptive Biotechnologies. So with that being said, Lanny, thank you for being here and welcome, and I'm looking forward to this conversation.
As am I, Rafael, and thank you very much for giving us the opportunity to chat today.
Oh, it's my pleasure. And, you know, there's a lot of excitement. And as you know, we have this new tool that's available for the detection of minimal residual disease testing. This is one of those topics that I think there's plenty of discussion about, but for some in our audience, this may be basic, but I wanted to review just basically, you know, what is it and how do we go about doing the testing and, you know, talk about some of the practicalities of this assay for MRD detection.
So that's great. And so, Rafael, I guess the place where I'd like to start, and feel free to, you know, move me along or clarify as needed, is that while what we're going to be talking about today is a new tool, the concept of minimal or measurable residual disease is almost as old as oncology itself. A patient presents, the size and extent of their tumor is assessed, some therapeutic intervention is done, and then the efficacy of that intervention is assessed by some means. And in hematopoietic malignancies, you know, that means often over the past decades has begun by looking at a bone marrow sample, by staining that bone marrow aspirate, and by counting the number of malignant cells that were present. And a trained hematopathologist could probably assess that at the level of, say, 1 to 5%, by which I mean if 1 to 5% of the abnormal plasma cells or lymphoblasts or whatever were present, then that could be ascertained. Minimal residual disease was the term that came to be used as the accuracy and sensitivity of being able to do that kind of assessment moved from strictly a visual one under the microscope to a submicroscopic level. But the same basic idea was still present. You were still looking at the onset when a patient first presented, and then seeing what happened to their disease in response to some sort of intervention, and then continue to follow them during their continuum of care. For hematopoietic malignancies like myeloma, there are, as you know, a number of ways of continuing to do that, a number of ways which look beyond just abnormal cytomorphology. Those things would include looking for free light chain or M-spike or protein electrophoresis, looking at flow cytometry, and probably what we're going to be discussing at some length today, now looking at actual sequencing of the immune receptors of the immunoglobulin heavy and light chain genes that happen to be present within the myeloma cell itself.
So one of the things that is fascinating to me, and having come from a general training in hematology and oncology, is how sophisticated these determinations can be made, particularly in the case of B-cell tumors and T-cell tumors as well too. But I'll share with you an analogy before we get down into the details of the assay. But I was at an AACR meeting where they were talking about biomarkers, and I made the point that by nature itself, B-cell tumors are the human cancers that have the best biomarkers ever, hands down, no question. And the reason for that is because we have a number of ways in which we can assay the presence or not of the tumor cells or indirect markers of these tumor cells, such as could be, the monoclonal proteins or the free light chains, as you alluded to. And one of the very unique features that B cells have is that because of the genetic editing of this really creates a very unique DNA fingerprint signature for the tumor we're tracking. So our ability to track for this is obviously, I think I would say without parallel in any other human tumor. I think we still are evolving in how do we use that information to make clinical decisions, and we'll talk more about that. But it's really a treat, if you may, just to have that many set of markers, because we can integrate that information. I use the analogy of it's like flying a plane, a small plane like a Cessna, a plane where you have all these little dials, and we integrate that information to make decisions. And the newest dial on that dashboard now is this MRD testing. So for those who are not familiar, how do you go about testing it in the clinic? And, I know we do this, of course, in our clinic, but if you don't mind just walking us through that process.
Sure. So as we've discussed, there are a number of ways of looking at the residual tumor in a patient during that patient's therapeutic interventions and continuum of care. The sequencing-based analysis of MRD required two fundamental things, which have occurred over the past few decades. The first was a deep understanding of how we normally generate immune diversity, the ability to respond to the myriad of antigens or pathogens with which we may or may not come in contact in our life. And then the second major advance was advances in sequencing technology, which have really just occurred over the past, say, 15 to 18 years, and have really revolutionized. I don't have to tell you, you can actually read the paper any day. You can now have your own genome sequenced or look for particular kinds of predispositions or mutations, but that has really been a revolutionary kind of advance in technology. That basically means that what we talk about now when we're talking about sequence-based residual disease, and you referred to it, we're really not talking about a surrogate for the disease. We are actually capable of identifying a biomarker that is the disease itself. It resides within the malignant cell. The reason why we're able to do that is because, again, as you know, but just to sort of frame the process, antibodies are specific for specific antigens or pathogens, and different plasma cells make different antibodies. That specificity is created in the antibody encoding DNA of B cells as those B cells develop and differentiate. So the DNA in one B cell clone that recognizes one particular antigen or pathogen and that has gone through that phase is no longer the same as the DNA in a different B cell clone that has reached a similar stage of its own development and undergone an analogous but distinct kind of creation that allows it to recognize a different antigen or pathogen. And the DNA in all of those B cell clones is not the same as the DNA in any other cell in the body. So the sequence-based assay looks at precisely the region of DNA that confers that antigen or pathogen specificity, which is unique again to a B cell and all clonal progeny of that B cell once it has passed through that stage of differentiation. You can then sequence all of those different hypervariable or antigen specifying regions in all of those different B cell clones in any given sample. The number of different sequences you see corresponds more or less to the number of different B cell clones that are present in the sample. That is the repertoire of potential antigens to which those B cells can respond. And the number of times you would see any single one of those sequences in that sample would correspond to the size of that clone within the sample. So, as you know, when you've got a situation like a myeloma and where there's an abnormal proliferation of plasmablasts in the bone marrow, the sequence that resides within those plasma cells, within that plasma cell clone, becomes dominant over all the other sequences that are present from all of the other B cells that are present in that bone marrow sample. You can identify that sequence. That sequence is unique to the malignant plasma cell, and then you can track that sequence with exquisite sensitivity over the entire continuum of care of that patient, where the sequence will either be present or absent. If it's absent, it means that at that point within that sample, there is no evidence of disease. And if it's present, you can say, well, there is evidence of disease, and because the assay is robustly quantitative, you can even say how much disease is present and follow that as it trends, either increasing or decreasing or staying the same over time during the care of that patient.
Yeah, and that's the core of this. From the very practical perspective, us in the clinic, what we do is we, let's say we see a patient that comes to us, a patient who's going to go through a stem cell transplant as primary therapy for myeloma. It's not unusual for those patients to have had a bone marrow on the outside. So the way this works out, we actually get a hold of those samples. It can be slides that are stored in a pathology department, and those are sent for analysis. And what's fascinating, so you do the PCR looking for those sequences, those DNA fingerprints in that original sample. And as you were saying, there's clearly always, not always, but when you detect it, is a dominant peak, and that becomes the signature to be tracked down the line. So, you can do that with older samples, and that's probably one of the really key aspects of being able to do this, because otherwise you would have to see the patient right from the first time at your center, and you really don't have to do that because you can identify the ID from older stored samples.
Yeah, very good point. What we're looking at here is genomic DNA, and there's an advantage because in general, DNA is pretty stable. We're all familiar with, DNA that is being recovered from mosquitoes in amber,
I
from.
knew you were going to go to Jurassic Park, but there we go.
Right, exactly. But DNA is pretty stable. And so, we can certainly use archived samples, formalin-fixed paraffin embedded or bone marrow aspirate smears on slides or fresh samples, whatever. Basically, we can use that, extract the DNA, and if a dominant plasma cell clone is present, identify that clone by the sequence or sequences that reside within it, and then follow those sequences over time. The other point that I'll make is that the way that the assay currently is done is that it doesn't require customization. So essentially every antibody is sequenced within a given sample, but we look for the dominant sequence or sequences in the diagnostic sample. And then over time, again, we get continued samples from patients as they undergo their treatment regimen. And again, we look at every B cell in whatever the samples are we receive, but we then specifically ask, is the sequence or are the sequences that we identified as being residing within the abnormal population at diagnosis, are they still present? And if so, at what frequency?
And that's a critical point, Lanny, because I mean, there were some previous attempts like with ASO, PCR and other techniques, but really by having this, I'm going to call it, and correct me if I'm wrong, but this unbiased approach, you're going to get reproducible amplifications as you see with the initial detection of that dominant clone, meaning you don't have to worry about the design and whether you have a new set of primers that maybe are going to work. Sometimes they won't work, they won't be efficient. So all of those variables are accounted for by this more wholesome approach, if you may.
Yep, a critical point, and it's also something that allows for reproducibility within a given patient over time and between patients, so that if we say, that the level of disease is 1 in 100,000 in patient A, and it's 1 in 100,000 in patient B, you can actually compare those two patients because the assay is robustly quantitative. It has been extensively calibrated and standardized and has undergone a variety of analytic validity kinds of measures in order to demonstrate its accuracy and reproducibility.
Well, you beat me to the punch there because I know you don't want to go too much into the technical aspects, but I just wanted to say that there's a high level of reproducibility, and also mathematically the likelihood that you would have, that sequence be repeated, it's really minimal. I mean, it's a highly unique feature. You can estimate that, and we put a lot of zeros, before you make an estimate of the likelihood of that being repeated. But it just has the quality metrics that are needed to have confidence in what you actually are reading as a sequence.
For sure, not all immunoglobulin sequences are created equally. But certainly the vast majority, and if in particular you're looking at the immunoglobulin heavy chain locus, the process of their creation involves enormous variation at the time of their creation, such that they, for the most part, really are essentially unique to the cell in which they have been created and all clonal progeny of that particular cell, and are distinct from every other sequence encoding every other immunoglobulin heavy chain gene throughout the body, or for that matter, in a general population.
So, I hope we have patients that are tracking along with us, no pun intended there, but let's move on to the tracking. Because I think people are going to be interested in knowing, okay, once you have the assay, you identify that, and as you mentioned, you can repeat that. So in our center, for instance, we would do that a determination of what's the sequence that allows us to track the clonal cells. And then our first point of determination usually will be at 3 months out from the stem cell transplant, what we call the day 100 visit. And this has become an integral aspect of how we identify the presence or not of residual cells. Obviously, if we have a situation where we have a patient that our pathologist would tell us, listen, there's 10% plasma cells, it's pointless to do this. This is an assay that is really geared towards further qualifying those patients that have very, very deep responses, namely and primarily complete responses, but very deep responses, trying to look for the presence of residual cells above and beyond what a pathologist would do. And, so we send that assay with that bone marrow sample that is collected at the day 100. And we make that an integral part of our discussion with patients when they come back to gauge the amount of progress that has occurred with the transplant itself. So I was going to ask you, so the tracking, that's how we do this. Tell us a little bit about just the practicalities, the turnaround time, and how does that work out?
Sure. So just a couple of points. So there are a number of specific aspects of using this technology that are relevant. And you've touched on certainly the first one. One of the most significant prognostic factors is response to a therapeutic intervention. And that is simply done by, you know where you started at diagnosis, and then you can say, well, where am I now? And certainly the better you have responded at that time point, the better the prognosis, or the better the prognosis is for a given patient. You can then also follow that patient over time and see, does the level of disease continue to drop? Does it level off, or does it increase? And then make therapeutic decisions to some extent based on that, along with all of the other factors that a physician like yourself would be thinking about with regard to a given patient. We can, if at day 100, for example, you send us a fresh bone marrow sample from a patient, we can get you the result back within a week. Actually, there's nothing about the test itself that requires more than, say, 4 days, but simply because of the processing and personnel, et cetera, the turnaround time that is stated is 7 days.
Thank you. One of the things that you alluded to, and I think that probably the best established clinical utility or use of this is actually when it comes down to prognosis. And we have 2 meta-analyses that have shown that determination of MRD testing is of high significance. I want to make reference to a recent paper that was published in September by the French group, a paper you participated in, collaborated in, where they looked at MRD status as a prognostic factor, and the power and the hazard ratio associated with MRD detection and discrimination for prognosis is really astounding. And the ability of what they were able to show with regards to correlation to clinical outcomes. I think we're all hoping that we can move into a future and working with the regulatory authorities where this becomes an integral part of, the future process of drug development, just because, the survival for myeloma patients continues to increase, and the use of overall survival requires many, many patients and a very long period of follow-up. And I think that the argument that, it's being made that potentially we could start thinking about how do we integrate this in the regulatory process. That's more for the drug side. But let's talk about the paper itself. I wonder if you could make some comments about that. I think it's probably one of the most important papers that has addressed this issue of sequencing-based MRD.
Yeah, certainly. So, you had referred to a couple of meta-analyses, which, again, used a variety of technologies and which showed that MRD negativity in general was one of, if not the most significant prognostic factor in terms of outcome for patients with myeloma. And those meta-analyses had been done over a number of years, and they used a variety of techniques. The paper that came out this year, that was a study from the French intergroup myeloma consortium, focused on It looked at flow cytometry, but also next generation sequencing based analyses. And as you pointed out, there were a number of points that were made there. The idea of the study was that they were comparing autologous stem cell transplant to a more consolidation, prolonged consolidation. And then there was also a 1-year maintenance regimen, and they looked at residual disease pre-maintenance and then following that 1 year of maintenance. And there were a number of points that they made, which I think were quite significant and which are quite provocative in terms of where we would go now in terms of the data. So the first thing was that the sequence-based MRD, which, you know, as you point out, has been called minimal residual disease, but as you're about to hear, probably should be called measurable residual disease in order to retain the M, but to say what it really represents, was a very highly significant factor in terms of the prognostic determination for these patients. And that was true either pre-maintenance or post-maintenance. Patients who were MRD negative routinely and did significantly better than patients who were MRD positive at one or the other of those 2 time points. It was also true that if you compared the result using sequence-based analysis, it was much more meaningful than other kinds of currently employed methods of analyses. So, for example, you know, CR as determined by some of the protein markers that you alluded to or that you mentioned earlier. If you looked at patients, all of whom were in CR, you could still distinguish patients who did better or worse based on whether they were MRD positive or negative by sequencing. If you looked at patients who were all negative by flow cytometry, you could still distinguish 2 groups, one of whom did better or worse in terms of prognosis based on whether they were positive or negative by sequence-based technology. Furthermore, if you compared the 2 arms, those patients who got transplant versus those patients who didn't, no question, interestingly, those who were transplanted in that study turned out in general to do better as measured by MRD negativity. More patients achieved MRD negativity. But in either arm, if you achieved MRD negativity, you did equally well. So from the MRD standpoint, the important thing was not how you got there, but that you got there, okay? And that actually mirrors the kind of data that we have seen from other kinds of studies, which we're not comparing transplant or not, but which we're looking at different therapeutic regimens where, again, we're seeing the hints of the same kind of thing. It was also true that if you looked at pre-maintenance and post-maintenance, those patients who started negative pre-maintenance and became negative post-maintenance and continued to be negative post-maintenance did very well. But patients who started positive pre-maintenance and converted to negative post-maintenance did equally well. Again, unfortunately, those patients who started negative and converted to positive had a more difficult time. And those patients who never achieved MRD negativity were those who, again, did or had the worst outcome. And I think this has raised issues of how does one proceed? What kind of trials should now be invoked, which is, I know, something that you're very focused on as well. The only thing I'll say is that there's now a companion study of that French study that's being run by, or being guided in particular by the Dana-Farber. And we hope that we will have the opportunity of also seeing somewhat comparable data coming out of that study in the not too distant future.
You know, this is really turning things on its head as far as how we interpret, how we measure outcomes, and how we can predict long-term outcomes. Just a few more comments. There was a Spanish study that was published in 2011 that had shown that, you know, for patients that are treated with transplant, if you got into a CR, which back then was 30% of patients got into a CR and had a 20-year follow-up, about 30% of those stayed in that complete response, meaning effectively you had a functional cure in about 9% of patients. Now, that same group went on to then subsequently apply measurements for MRD and showed that if you apply that to those in CR, essentially CRs are just as good as PRs. So what it means is that our, you know, efforts and all of our meetings to create classifications of response to myeloma were useful at the time, but mostly an academic exercise, because then, of course, you know, what it means is that you need to get to very, very deep levels of response. And where things get real interested with me in this paper is that, you know, this paper shows what you already alluded to, right? Well, the important thing is to get into MRD. Now, a comment, and I'd be interested in hearing your thoughts about this, a comment that can always be made for situations like this is, well, is this biology or is this treatment? And my answer to that is unequivocally is both. You know, there are some patients, and we have patients in our clinics that can receive a minimal amount of treatment and have excellent long-term results. But the reality, when you have a randomized phase 3 study like this, you see that different treatment interventions reach different levels of MRD negativity. And what I would be happy to argue with anyone right now is, as we're thinking about the design of future clinical trials, or as we're thinking about which strategies to use for the treatment of our patients, at point zero, so before we start any treatment, I think from what we know now, it makes sense, particularly for those patients that are candidates, for instance, for transplant, to choose that pathway that will give you the greatest likelihood of your patient achieving MRD negativity. And this is you know, not to say that if someone has a response and hasn't gotten there, that we can logically conclude that change to a different strategy is a good thing to do. I would argue, I hypothesize it is, but we don't have that data. But from the get-go, you have to choose the regimens that are going to give you the deepest responses and possibly being associated with the highest level of MRD. Now, there's something else that is fascinating from the study. They actually broke down patients into the risk categories. And if you asked me 6 months ago, I would tell you, well, you know, high risk, absolutely, we need to get them into MRD and we need to have that sustained MRD. Maybe for those that have standard risk, you know, we can tolerate some lower level disease. And what they were able to show in this study is that MRD breaks both high risk and standard risk into better and worse outcomes. So in other words, it is not clear to me that a more sort of paused approach or a more quiet or a less intense approach is clearly warranted for those that have standard risk. And if anything, what we can see is that, you know, the treatments help more those that are doing better. So there's a lot of head scratching going on, certainly in the myeloma community, with studies like this.
Yeah, so again, you know, I mean, as I was listening to you, I was thinking of, I mean, how amazing it is and how wonderful it is to some extent to be able to actually have this kind of conversation where suddenly, you know, we're talking about myeloma as being curable or at least controllable for a number of patients. You know, this has been a long time coming, although there's been so much progress within the past few years that it's also been just kind of amazing, a privilege to be able to witness this kind of transition in all of our thinking, but certainly in the approach that people like yourself, who are specialists in treating myeloma, are now dealing with. You know, this paper made some points which I think are quite relevant. Although it looked at different thresholds, one of the messages that it seemed to say was that, yes, but MRD is a continuous variable, which is why we, again, are beginning to think that perhaps MRD is measurable residual disease as opposed to minimal residual disease might be a better way of phrasing it, where the deeper, the better. And that, you know, are we at the point where we can identify, you know, a particular threshold beneath which at a certain point in time patients are now cured? No, but we can say, I think, that the deeper one's response to a particular therapy, the better. And some of those patients who have very deep responses may in fact be cured of their disease, or at least have very long-term control of the disease process.
Yeah, absolutely. I think so, and I'm quite vocal about this. And I actually talk to my patients under those terms. I think, first of all, we don't know what the long term will be, but as you are seeing patients that are coming back from their transplant who get optimal induction therapy, and are not only achieving MRD, but then when we repeat MRD down the line, we see a sustained MRD negativity. It doesn't take a lot of imagination to think about long-term benefit. Now, there are patients before we did MRD testing who are many years out from transplant who are doing well. So I think what we're talking about is probably a better tool to prospectively be able to identify these patients. Now, I'm just going to state the obvious, and I want to ask you a little bit about the limitations as well too of an assay like this. But the first and most obvious one relates to logic, right? It's impossible to prove a negative. So, you know, you can only say to a certain point that you don't find those cells. So in other words, we have no evidence of disease. We can never claim that there is evidence of no disease. You know, if you took an organism and you wanted to prove that there's evidence of no disease, you would have to test the whole organism for that, right? So you can only take it to a certain level. But the reality is, even though you cannot necessarily go about proving that negative, that resolution gives you a level of comfort that, you know, that tells you you're in a much better spot than if you were not necessarily achieving that threshold. And that's number one. Number two is, I think, as we incorporate another dimension, which is time. So if you have someone who's MRD negative now, and say it's repeated MRD negative a year and 2 years from now, I think the level of comfort of those determinations is great. Can you ever say it's 100%? Of course not. But I think that's a great way to start your path towards long-term control or cure of myeloma.
Absolutely. I think what you've basically said is that at any given point in time, the level of residual disease is a relevant measure. While it's absolutely true that, you know, someone could say, well, but how deep does one have to go? You know, I mean, if you had an assay that could identify 1 in a trillion cells as being, you know, residual myeloma, what would that mean? You know, my answer when I get asked that question is, I have no idea. I do know that if we had a choice between 1 in a trillion or none, we would all choose none, okay? But we are operating, at least on a practical level, within a range where it does seem that for the populations that have been studied, deeper is better. Being MRD negative is better. To your point, it does not mean that there is, that by itself, that patient is cured. But we do know that patients who, you know, have less than 1 in 100,000 residual cells at a given point in time do better than patients who have 1 in 10,000, and that patients who have 1 in a million, you know, less than 1 in a million, do better than those patients as a population that have 1 in 100,000, and that many now of those patients who are then tracked and continue to get MRD assessments over time and continue to be negative or to show a decrease in their level of residual disease, have long-term, very positive outcomes. And to some extent, at least for those in whom there has not been residual disease detected for some prolonged period of time, um, one never knows, but it isn't completely fantasy to begin to think of them as possibly being cured.
Well, Lanny, and you're training pediatric oncology, and I don't think it takes a lot of imagination to go back now 40 and 50 years and think, okay, myeloma, we're going to incorporate MRD and we're going to do optimal induction. Maybe we'll do transplant, and if you're positive post-transplant, maybe we'll do CAR T cells, and if you're negative, we'll do some other form of maintenance, which really that was the path for the cure of childhood leukemia, with different drugs, a different scenario. But it's really, I don't think, again, it's being naive or Pollyannish, but it's within our reach to be able to do that.
Well, you're really making me smile. We published a paper. Brent Wood was the first author, and it was based on a children's oncology group study which looked at standard risk ALL patients and high risk ALL patients. That was published earlier this year, and as a pediatric oncologist, there was one particular finding that when I saw it, I couldn't help but smile, which is that for standard risk patients who were MRD negative at the end of induction, okay, just that was day 29, end of induction, their overall survival was 100%, and they had been followed out more than 8 years.
Wow.
So, I mean, that's the kind of finding that when you see it, you know, it's just a wonderful thing, and it just underscores the possibility that we may be in a very different phase given interventions that are now possible and ways of measuring the response to each of those interventions and of monitoring patients over time, where we can really begin to think of potential cures, but also begin to think of, well, when are additional interventions required?
Sure. And you know what, for any of us, we are concerned about longevity of treatment. We are concerned about expense-associated treatment. We are concerned about toxicity with treatment. It turns out that using tools like this in combination with combinatorial regimens, just as the same as happened with the children, that you had started omitting a few things, you can actually achieve so with a shorter, more intense duration of treatment that's more tailored and responsive to the dynamic changes and measuring of the disease.
Well, I mean, yeah, let's hope so. Again, I mean, as a pediatric oncologist, obviously the treatment of childhood ALL has been one of the great success stories over the past 50 years. But it's a very intensive, aggressive kind of therapy, which does have long-term sequela for many of the patients who are treated. And if there are ways that using more refined techniques for measuring disease and more precision kinds of therapeutics, it would be possible to achieve control of the disease or even cure less intensively or aggressively with less long-term sequela. That would obviously be, ideal, and that's a goal that I think to which we can all aspire. And I think something now, given where we are, both in terms of therapeutics and in terms of measuring residual disease, something which we can really contemplate in a more rigorous, very kind of organized fashion in terms of how we might try to achieve that.
Hani, I don't think the audience would let me go if I don't ask you for the limitations and the concerns, or what should people be thinking about and be careful as they think about MRD testing?
Yeah. Whatever method that you're using, I think you've actually touched on a number of the critical points. This is a highly accurate, specific, and sensitive measure of disease, but it is only done within the confines of what the sample that is sent, the quality of the sample that is sent, the number of cells that are analyzed, the point in time at which the measurement is made, and the time course over which the various measurements are made. It's something that I think is a useful tool. It's something that has to be combined with all of the other signs and symptoms that are present for any given patient. And, ultimately, it's like any test. But it, I think, is an important test that now adds value and that is being done in a way that can, I think, really help in the clinical management of patients. If there are specific issues that you're thinking of in terms of the limitations,
No. I think you cover them. They really are all centered around the sample acquisition and how do we get the proper samples. There's always a fight for who gets the first part of the aspirate, who gets the second part, and that's always tricky. I think standardization of that will be important. I would love to see a future where MRD, just as you stated, has that ability to have a spread and quantification, such that we have a patient who say has a few cells that is MRD positive post-transplant, and we are to put that patient on a maintenance regimen, whatever drugs that would be. And then you could track over time, just like we do with the light chains or any of our other markers. And, if your maintenance is given, but then the clone seems to be emerging, well, before you have symptoms, you may want to reconsider. On the other hand, if you have maintenance that seems to be working and the clones are disappearing, and maybe the patient needs some reassurance because every treatment has side effects. And maybe the patient needs to say, listen, we are making progress. How does this, square off for you? Is it worth it that we keep on this therapy? They may want to know that and then think about continuation of therapy.
Yeah, and those are certainly things that, again, we routinely want to learn from you in terms of how you are incorporating, these data into your thinking about how to manage the patients that you of whom you take care. You are, correct. Obviously, the quality of the sample that we receive is key, and but that's true for any test. And the only thing that I would just say is that, well, the sample that is sent should best represent whatever the question is that you're trying to answer. And we hope that because of the accuracy and standardization and sensitivity, that we might be able to begin to move toward the use of less invasive kinds of sampling techniques, which would be obviously, I think, good and appreciated by the patients. And that's an area of active investigation. And we obviously also, again, like any, are very anxious in working out with the people who are using the test how to get the samples, what the best samples are, how to do it in the easiest and most judicious way, and also, frankly, how to take a test that has been developed in a particular place and disseminated so that it will be more available either through reference labs or through tertiary care centers, and make it even easier for physicians and patients to be able to utilize this as one of the tests that are incorporated into their overall care.
And going back to my analogy of the test, and I'll tell you something where I have used the assay, and that is in patients who have long-term sustained CRs, particularly when those patients are on maintenance approaches. Without this test, so before we had this available, we would have patients that are on maintenance long-term. And over time, sometimes this takes a toll in a number of ways. A common way, for instance, would be with lenalidomide long-term maintenance. There can be some toxicity that is cumulative. And the conversation always goes into, well, what do you think I should do? Should I keep going? Sometimes with no other bit of information, but just the patients telling us, it's hard for me, we have to stop treatment. And so I brought the test into that scenario for patients who are on long-term complete responses. And if the patient has a sustained MRD negativity, I think that's one more bit of information that comes into the table. And in some cases, just as could be done empirically without the test. In some cases, we have stopped the maintenance, and the person feels a little bit better. And of course, no one knows exactly the prediction from that, but it's again one more piece of information that helps us as we try to decide what's best for that particular individual.
Yeah, I mean, I think that that is the hope, that this is something which provides an aid to individual physicians to use at their discretion in the overall context of the patients with whom they're dealing, including all of the things that are going on with that patient, both in terms of the disease and the side effects and so on. So, and that basically, again, I keep on saying it, but that's the way most tests have to be.
Exactly. Well, Lanny, we've talked for a while. I really appreciate your willingness to be here for this conversation. We didn't even touch on all the other diseases. I think the potential for other B cells and T cells, and I know you as a company are exploring that. But any final words of wisdom? And after you do that, I'd like to share an anecdote about you and I that I hope you find humorous. But any final words of wisdom?
It's been a wonderful thing. The use of immune receptor profiling for measurable residual disease determination is, the application that has the greatest precedent, as I said at the beginning. It's just another more sensitive way of doing what oncologists have been doing for years. But it underscores, what an incredible system the immune system itself is. And certainly, being able to profile it in this way has applications that are hopefully, I think we've made the point, absolutely relevant as an aid to the management of patients with lymphoid malignancies. It's finding use in patients who are receiving immunotherapies. I'm guessing that it will perhaps be of interest for patients who have infectious disease or autoimmunity, or want to know how they've responded to a particular vaccine, or whether their bone marrow transplant has reconstituted. And, we look forward basically to seeing how this knowledge, which is developing at such a rapid pace, can be used for the betterment of health and society in general, and obviously for the amelioration of situations of patients who face grievous illness.
Well, thank you very much. This is inspiring, and I look forward to those conversations in the future where you talk about those other applications. Now, to the anecdote, I have gratitude for something that happened about 20 years ago. I believe you were the chief in 1998, correct? Somewhere around that time.
Of the genetics branch?
The genetics branch, yeah. So I was a fellow, and that's where I met you. And I went to work under Mike Keel. So you were the boss of Mike Keel. Mike Keel was my boss. And I think it was probably my second day, and I don't know if you remember this. You probably do. It was my second day in the lab. And back then, we were not working with fluorescence. We were working with P32. And there was that little culture room to the side. And Mike sent me to do some experiments. And I was quite inexperienced in the lab. And so lo and behold, before we know it, there was a radioactive contamination of the lab. And now I was so intimidated because, you were the big boss, and this was a naval hospital. So the naval police came in with their Geiger counters, and they started following the droplets. And guess where those droplets ended? They ended up at my desk. I thought I would never be able to return to that lab, but you were gracious enough that I was able to do that. And of course, that was a big part of my professional development experience. So I hope you remember it with fun now, but at the time I was so stressed out.
Well, I'm glad it all worked out, actually, but you have brought up a couple of things which it's very nice to think about. First, it was actually quite wonderful and quite instructive to be able to work at the Naval Hospital with the Navy team, the surgeons, as well as just all of the personnel who worked there. It was quite a privilege for all of us to be able to work in that environment. And last but not least, you have brought up Mike Keel, who is just, a wonderful person, an enormous mentor, actually, for many, many people, including me, and also someone who, more and more as I think more and more about myeloma and some of the things that we've been talking about today, I appreciate his enormous contribution to the identification of risk categories of myeloma, the definition of all of the different cytogenetic abnormalities in myeloma, and his tutelage of you, but also of two people with whom I know you are closely affiliated at your institution, Leif Bergsegel and Marta Casey. So he was, again, a wonderful person to have in the lab, and really an inspiration for many people, not just you, but me as well.
He has been and continues to be, and we have a tremendous debt of gratitude to Mike for everything he did. And clearly, I would say the founding father of myeloma biology, and as we understand it today. So I'm so glad you pointed that out. Well, thank you very much for your time, and I look forward to see you pretty soon.
Okay, take care. Thanks again.